Welcome to the Diabetic Mogul Podcast. Greetings, friends, family, diabetes community, patient advocates, caregivers, and everyone listening. My name is Untitled, and I'm extremely excited to be hosting this podcast in the most authentic sound of my voice. This episode will focus on the diabetes education in people with type 1 diabetes, especially children and adolescents. And it is my hope that you'd find this educational, encouraging experience to help you and your loved ones to improve on your glycemic goals. Above all, I'm eternally grateful to share with you the key insights from T1 International, ISPAD, and other standards of care in diabetes. Thank you. Checking on your blood sugar. Why should you? There are 3 reasons for checking your blood sugar. To see how insulin affects your blood sugar, to be certain your blood sugar goes down with each injection, and to make sure your blood sugar does not go too low or too high before your next injection. Introduction. Diabetes education is a critical element of diabetes therapy regardless of the intensity of the regimen adopted. Diabetes management requires frequent and high levels of educational input at diagnosis and ongoing to support children and adolescents as well as parents and other caregivers. Diabetes education has been shown to be very cost-effective intervention through savings from reduced frequency of hospital admissions and emergency presentations. People who do not receive education or do not continue to have educational contacts are more likely to suffer diabetes-related complications. Diabetes education needs to be adaptable and personalized to each individual's age, stage of diabetes, maturity, and lifestyle, culture, and learning pace. Diabetes education needs to be a continuous process and be repeated for it to be effective, and it should be based on a thorough assessment of the person's attitudes, beliefs, learning style, ability, readiness to learn, existing knowledge, and goals. Now, what is diabetes education? Diabetes education is an interactive process that facilitates and supports the individual or their family, those who provide care or significant social contacts, to acquire and apply the knowledge, confidence, and practice problem-solving and coping skills needed to manage the life with diabetes in order to achieve the best possible outcomes within your own unique circumstances. At diagnosis, families have been seen that educationally they are unreceptive due to the emotional stress of diagnosis. Never forget that diabetes care includes both medical treatment and education. Once your diabetes has become manageable, so will other aspects of your life. Diabetes education in intensive treatment methods. What are these? Matching and adjusting insulin profiles to quantified food intake and exercise levels is an important part of any intensified diabetes management. More complex modern therapeutic regimens with multiple daily injections, use of different insulins and insulin analogs, continuous subcutaneous insulin infusion, as well as wearing continuous glucose measurement devices require appropriate education and training. High levels of education and understanding are required for these interventions to be successful and require more time, skill, greater resource from the educational team. Changing from one form of insulin regimen to another as the only means for intervention does not improve the metabolic control. So education is very key. Now, advancement in technology combined with widespread adoption of digital devices by people with diabetes and their clinicians have created an opportunity to leverage the digital platforms to augment diabetes care. The available newer technologies include smartphone, web-based applications, computer games, text messaging for information, etc. These technologies are most effective when they include interactive modes and utilize social media. Because technology-based diabetes teaching systems are designed to serve different purposes such as tracking, monitoring blood glucose activity or exercise, health eating, medication adherence, monitoring for complications, annual screenings and problem solving, and calorie and carbohydrate counting. Smartphone applications help people to tackle the abstract concept of the carbohydrate content in the food. Digital diabetes tools have been designed for coaching people with diabetes by personalized diabetes education. And also, diabetes tools may have Their greatest role during the 4 crucial times for diabetes self-management education: 1. At diagnosis, during an annual assessment by the healthcare provider when complicating factors arise, and during transitions in care from childhood to adolescence and from adolescence to adult care. So then the clinicians and the tech experts and scientists should warn their users regarding the potential inaccuracies or the potential breach of confidentiality and the risk of being overwhelmed by web-based information, and guide their patients to websites and mobile applications that are trustworthy. So that means not everything is trustworthy. So diabetes at diagnosis, what does this entail? The management of diabetes in children and adolescents cannot simply be derived from care routinely provided by adults with diabetes. The epidemiology, the pathophysiology, developmental considerations, and response to therapy in pediatric onset diabetes are different from adult diabetes. There are also differences in recommended care for children and adolescents with type 1 diabetes as opposed to type 2 diabetes, which I hope I will touch on my next episode. It is essential that diabetes self-management, education and support, medical, nutrition therapy, and psychosocial support be provided at diagnosis and regularly thereafter in the developmental appropriate format that builds on prior knowledge by individuals' experience with the biological, educational, nutritional, behavioral, and emotional needs of the growing child and family. Now, moving on, diabetes self-management education and support. No matter how sound the medical regimen is, it can only be effective if the family or the affected individuals are able to implement it. Family involvement is a vital component of optimal diabetes management throughout the childhood and adolescence. I've actually experienced this when I was actually growing up. Diabetes self-management education and support requires periodic reassessment, especially as the youth grows, develops, acquires the need for a greater independence, self-care skills. Moving on to nutritional therapy. Individualized medical nutrition therapy is recommended for children and adolescents with type 1 diabetes as an essential component of the overall treatment plan. Monitoring carbohydrate intake, whether by carbohydrate counting or experience-based estimation, is key in achieving optimal glycemic control, which is what I use. I use the experience-based estimation. Comprehensive nutrition education and diagnosis with annual updates by an experienced registered dietitian or nutritionist is recommended to assess caloric and nutrition intake in relation to weight status, cardiovascular disease risk factors, and to inform the macronutrient choices. Moving on, physical activity and exercise. Exercise positively affects insulin sensitivity. This should be known. Physical fitness, strength building, weight management, social interaction, mood, self-esteem building, and creation of a healthful habits for adulthood, but it also has the potential to cause both hypoglycemia and hyperglycemia. Exercise is recommended for all youth with type 1 diabetes with the goal of a 60 minutes to a moderate to a vigorous intensity aerobic. Education about frequent patterns of glycemia during and after exercise, which may include initial transient hyperglycemia followed by hypoglycemia, is essential. Families should also receive education on prevention and management of hypoglycemia during and after exercise, including ensuring that patients have a pre-exercise glucose level and accessible carbohydrates before engaging in any activity. And also, patients should be educated on strategies to prevent hypoglycemia during exercise, after exercise, and overnight following an exercise, which may include reducing insulin dosing for the meal, for the snack, etc. Frequent glucose monitoring before and or during or after exercise with or without use of continuous glucose monitoring is important to prevent or detect and treat hypoglycemia and hyperglycemia with exercise. The glycemic control, what does this entail? The majority of children and adolescents with type 1 diabetes should be treated with intensive insulin regimens, either via multiple daily injections or continuous subcutaneous insulin infusion. All children and adolescents with type 1 diabetes should self-monitor glucose levels multiple times daily. A1C goals must be individualized, reassessed over time. An A1C of less than 7 is appropriate for many children. For some children without the hypoglycemia awareness, or those that we say the hypoglycemia unawareness, they lack access to the analog insulins, advanced insulins. Maybe a 7.5 would be appropriate for them. And even less stringent A1C goals, such as less than 8, may be appropriate for patients with a history of severe hypoglycemia, limited life expectancy. I think on this one you should actually see your doctor. Moving on to autoimmune conditions, the other underlying conditions. Assess for additional autoimmune conditions soon after diagnosis of type 1 diabetes and if any symptoms develop. Celiac disease. Screen children with type 1 diabetes for celiac disease by measuring the immunoglobulin A soon after diagnosis of type 1 diabetes. Repeat screening within 2 years of diabetes diagnosis and then again after 5 years, and consider more frequent screening in children who have symptoms of first-degree relative with celiac disease. Individuals with biopsy-confirmed celiac disease should be placed on a gluten-free diet for treatment and avoid complications. They should also have a consultation with a dietitian experienced in managing both diabetes and celiac disease. On the management of cardiovascular risk factors, firstly, we should start with the hypertension screening. Blood pressure should be measured at each routine visit. Children found to have elevated blood pressure or hypertension should have elevated blood pressure confirmed on 3 separate days. And what do you do for treatment? Initial treatment of elevated blood pressure includes dietary modification, increased exercise if appropriate, aimed at weight control if target blood pressure is not reached within 3 to 6 months of initiating lifestyle intervention. Then in addition to lifestyle modification, the pharmacologic treatment of hypertension should be considered as soon as hypertension is confirmed. And then moving on to retinopathy. An initial dilated and comprehensive eye examination is recommended once youth have had type 1 diabetes for 3 to 5 years, provided they are aged more than 11 years or puberty has started, whichever is earlier. After the initial examination, repeat dilated and comprehensive eye examination every 2 years. Less frequent examinations every 4 years may be acceptable on an advice of an eye care professional and based on risk factor assessment, including history of glycemic control with A1C of less than 8%. And lastly, I'll share on neuropathy. Consider an annual comprehensive foot exam at the start of puberty or at age which is more than 10 years once the youth has had type 1 diabetes for 5 years. And with that, I rest my case. Thank you all for listening, and I hope you'll find this educational. You'd share with the others that did not have the chance to listen. So with all being said, I thank you so much for listening.